Okay, so good afternoon, everybody. My name is Jen Levy, and I'm the Scientific Director at Coalition to Cure Calpain 3. I'll be the moderator for the Ask the Experts panel. Today's Ask the Experts panel is going to be on the topics of natural history and genetics and LGMD in general. And tomorrow's panel at the end of the afternoon will be about clinical trials and potential therapeutics. So if you asked questions related to those, I'll pass that on for tomorrow. And you'll get a chance to ask all those questions. Since we're starting late, I'm going to skip the introductions only because I think you've all been introduced today already, so I don't think anybody's forgotten you yet. I organized the questions into a few topics. So the first we're going to talk about today is the questions about the GRASP study. And maybe, Nick, you can take a couple of these, and the others in the GRASP consortium can as well, or chime in. But there were some questions about location. So are you planning on expanding the clinics to other countries? Somebody also asked specifically about the Deep South, like Houston and New Orleans. And on a related note, do you pay for travel?
Those are all good questions. I'm going to pass the expanding to other countries to Volker in a minute. But I think that, we're certainly interested in having an inclusive group I think that helps, particularly as we expand into more rare subtypes. In terms of the U.S. sites specifically, we've really focused on the expertise that is as geographically diverse as possible, and so we really paid a lot of attention to people who've got a lot of experience in the field and would be help us guide and develop those studies in the best possible way. Each GRASP study is different, so I really encourage you to go to the table in the exhibit hall and provide your information because depending on what subtype, we may or may not be able to provide travel, and that really we're quite restricted by what our funding source is for each part of the study. Volker, do you want to talk about expanding or the European efforts that would be in parallel?
So, I mean, one thing that we haven't discussed specifically is how much do these studies cost? And they do actually cost quite a lot. Like the dysphalanopathy study is in several millions. This is how much it costs to have 200 patients internationally enrolled. So we are very keen to get sites in other countries involved as well. But one of the bottlenecks is funding. So even though we are actively applying for grants and we have support from patient organizations, also working with industry, that will be one of the limitations. But I think what's very important and is also reflected in the consortium in the conference here is that we are talking to each other. So even if there are different initiatives in different countries, we want to make sure that there's harmonization across the studies. So, the dysphalanopathy study that Marathon mentioned is one example that there is a lot of willingness to work internationally across many sites, and I can see the same for GRASP happening as well in the next few years.
So are people from any country eligible to do the exams if they can get there?
Yes.
Okay. And also, do you have any plans to set up like a temporary center, like at a conference such as this?
Yeah, I mean, I think that would be Kathy could maybe talk about how this has worked in the past. But have people come together, I think that's worth investigating in the future. One of the challenges that we do want to make sure that we have the ability to follow somebody over a long period of time. So unless we keep coming back to Chicago, which is a great city, I would have concerns about kind of a one-time thing.
Okay, there was also a question about why are these studies, not specifically GRASP, but natural history studies in general, targeted towards ambulatory patients?
Yeah, so I think we didn't talk a lot about what the exact elements of each one of those natural history studies are. I think it is our expectation that particularly when you think about what early drug development trials might look like, is that those would probably start with ambulatory individuals. And so our first job is to understand the natural history within those individuals. However, some of the GRASP studies, and I'm not sure about other natural history studies, do include non-ambulatory individuals. So again, it's really dependent on the subtype. Yeah.
Yeah, me too. So the COS study will enrol patients who are ambulant and non-ambulant, and the whole point of that new North Star assessment that we made for limb girdle is that it will take you through your journey if you do become non-ambulant. That assessment is for ambulant and non-ambulant patients on one scale. So it has been addressed in limb girdle, and we are using that assessment for other limb girdle type muscular dystrophies, but COS does take ambulant and non-ambulant patients.
The Iowa Natural History Study Dystrophic Canopathies also takes both ambulant and non-ambulant.
Just a little further down the line too is that when you get to clinical trial development, a lot of drug developers want to make sure that their product has the most ability and greatest chance of showing a difference. So if you would go towards ambulant patients, usually with less severe changes in the body, then there's probably a higher chance than that is as a kind of a general paradigm. That's not in total true for every product, but in general, that's just something to consider.
Okay. And another question related to natural history is, how can natural history studies be used to shape clinical trials compared to applying real-world evidence? Can these be used synergistically, and can they be used as part of adaptive design?
It's a very sophisticated question. I feel like that's got Dr. Matthews' name on it, but no. So I'll take the other people. So I think the reason why we do natural history studies is that we're trying to eliminate variables that may unduly influence the outcome. So we spend a lot of time training our evaluators, and I can't emphasize that as much, and Meredith can talk about that as well, as standardization across sites between individuals, and to try and reduce variability on those outcome measures. And so, and the advantage of doing it in that way is that it best reflects what we expect to see in the clinical trial. However, those by definition and reflect a more narrow window into a disease. And so there are ways and other efforts, the CDC, for example, has an effort to obtain more real-world information about the limb-girdle muscular dystrophies, and it does all come together. I know the regulators look at all of it.
When and how do you plan to share the data that's collected with the participants in the study?
So I think for GRASP specifically, we're just now starting to enroll participants, but our expectation is that those publications will be made as available as possible. We count very much on efforts by Coalition to Cure Calpainopathy or the Jane Foundation, MDA, to help disseminate their results through communications that they have, and then we're always happy to come back and talk about where we are at meetings like this. How about COS2 or any of the other? No?
Yeah, can you speak about COS2?
So right now, the question was if we share data with patients individually. Is that what the question was, or?
I think it went more in general. How can they find out what you've learned from the study as a whole?
So, I mean, on the one hand, and Meredith elaborated on this, it's very important for us to publish. It's actually something that the regulators request. Ideally, whether it's the FDA or the EMA, they want to see peer-reviewed published data. It's very important. Anyone who does a study should publish, because otherwise you can't use this as support and evidence. And then it's exactly conferences like here that we share data. For the FKRP registry, we also have a newsletter where we keep patients informed about what's going on, both in studies and in research. So registries are also another way actually to disseminate information. I think a lot of the tools that have been introduced today can be used to feed information back to the patients, and if patients feel there's more demand, then it's good to hear this. Of course, advocacy groups are often in close touch with investigators as well. They have websites. So I think if you're interested in finding data, generally there should be a way that you can have access to them. it's while a study is ongoing, we cannot share data in detail because this might introduce a bias. And so normally we have to have a so-called data lock when the data can't be changed anymore, and then you can start to share them. Before then, just for the robustness, you shouldn't actually share data and look into them and interpret them.
And are participants able to follow their own progress through the studies?
So I mean, they're now, at least in registries, more sophisticated IT options where we aim to do this, that a patient, if you longitudinally enter data, get a readout, how have you done over the years, whether it's your respiratory function or your strength or your tests, if any of them have been done. But many of the registries are not yet there. I think for the newer ones and some of the registries that we are currently looking into, this is exactly what we want, that patients get feedback on their own data. So you can almost use it as a diary for yourself, not on a daily basis or more on a 6 monthly or yearly basis.
Just in terms of novel trial design, that's already going on. So the Fitbit data, that's kind of an interesting activity. There's initiatives to look at telemedicine for some of the visits so that for our patients that are spread quite a ways. And then there are a couple of other unique trial designs in other diseases where they self-record almost daily recordings or weekly recordings of biologic metrics. And then finally, one of the most intriguing studies that I liked is when the ALS community decided that they wanted to know if lithium worked, and so they just all got together online and they did a 6-month trial, and before NIH funding came through, they published the fact that no, it didn't work. And then we did an NIH trial and showed that it didn't work. Okay.
Great, so we're going to move on to the next topic of questions, and these are all generally around the topic of what can people do to slow their progression. The three that were specifically asked about were exercise, diet, and supplements, and if any of those could be used to slow the progression of disease. So let's start with exercise.
Take that one?
Yes, you can take that one.
So we, as physical therapists, can you switch it at the back? Thank you. As physical therapists, we would strongly encourage our patients to be active with an activity that they enjoy doing. There's exercise can be broken up into aerobic exercise, so the exercise that gets you a bit puffed, which the heart foundations around the world suggest that is good to do some aerobic exercise during the week. That doesn't need to be a run or a road cycle. It can just be something that makes you puffed. So if you play the piano, if you play the drums, if you use a cycle ergometer, just something that actually you're committed to doing is really good for your heart and cardiovascular health, but also good for your muscle condition. In terms of strength testing and strength, free weights, the gym, other exercise like that, we severely lack any quality studies in how exercise works in limb-girdle muscular dystrophy. Okay, we really don't, we have a dearth of information on that, and we would like to start doing those sorts of trials. What we can extrapolate from the animal literature is that doing heavy weights is probably not a great idea, but some gentle strengthening is going to keep the muscle fibers that are unaffected in good condition, but may not necessarily change the muscle fibers that are affected by the disease. Okay, do you want to do diet and supplements?
Well, with diet, I mean, there are probably various aspects of a diet. The main recommendation is to have a balanced diet. Clearly, in terms of weight, if you have a muscle wasting disease, being overweight is a disadvantage. But again, a lot of this is more common sense. If you ask about specific supplements that have shown, based on evidence, that they would benefit or slow down the progression of a form of limb-girdle muscular dystrophy, then there is no such study that has shown this. Nevertheless, for example, in the UK, it was already mentioned that we don't seem to have as much sun as in other places, where a lot of people have vitamin D deficiency, and we know that vitamin D deficiency alone can even cause myopathy and weakness. So therefore, we test all our patients for vitamin D levels and vitamin D deficiency, and then would prescribe vitamin D supplements. But I guess if you live in California, that's not an issue. So it depends a bit on also where you live. It's best probably to discuss with your GP about this. Then another supplement that has been tested across a number of muscular dystrophies, including limb-girdle muscular dystrophy, but not specifically, is creatine. And so there's some evidence also in a meta-analysis that it is beneficial. What I normally ask patients to do if they want to pay for it, because most insurers or health systems don't reimburse it, try it and see, and then you can stop after 3 months if you don't feel that there's any effect. There are some side effects, mainly gastrointestinal, diarrhea, maybe a bit stomach pain, but to my knowledge, there isn't really anything else that has shown for specific limb-girdle muscular dystrophy as a supplement or a dietary measure to be effective. I don't know whether anyone else wants to comment.
I don't have a mic. So can you guys hear me if I just shout? So one other caution in the U.S. is, I think it's pretty well known that that the supplements are not FDA approved, so you do not know what you're getting. And there have been a number of studies where chemists have taken supplements off the shelf and compared the ingredients in the bottle to the ingredients on the label, and they do not match. So particularly when you have a disease like limb-girdle muscular dystrophy that might affect the heart or something, you want to have a little bit of caution about what you buy off the shelf when you don't know for sure what's in it. It may be something that gives you more energy because it has a stimulant in it, and that may not be the best thing for your heart. So some caution is probably wise.
I think that's a very important comment.
Oh,
I think,
well.
yeah, so, but everyone heard you. I think very important comment, particularly when it comes to ordering these supplements through the internet as well. So there have also been some evidence that some steroids were mixed up with these performance-enhancing supplements, and you feel a lot better, of course, that you buy more, but it's a steroid in there, and with side effects. So yes, caution is important there.
Volker, would you answer one question? So the COS study, and specifically for dysferlinopathies, exercise early in disease. Do you want to comment?
Yes, so we have published on this. I think clinicians, when we diagnose patients with dysferlinopathy, often when taking the medical history, realize that these were patients that were very good at sport compared to any of the other muscular dystrophies, really. So it was quite apparent that there's something different. And in our large cohort of 200 patients, we then looked into more detail in the history of the patients in terms of doing sports. And there were a lot of patients that were very good in rugby and high school sports, some doing training more than 4 times per week. And because we had these long-term natural history data, we then looked how well did they perform in contrast to other dysferlinopathy patients. And we were quite interested to see that those who did a lot of sport, and we defined what a lot of sport means, were earlier wheelchair bound and had a quicker decline. So this is something very interesting and maybe a bit worrying as well, because we don't know whether, coming back to your question, we should actually now recommend to patients that are maybe diagnosed very early to slow down in terms of exercise. What is the right level of exercise? I think there's still not sufficient evidence to yet make any recommendations specifically that would advise patients, what is the right amount of exercise.
I had one more comment. In 2I, we did a similar thing, and whoa, it turned on. We did a similar thing in a smaller cohort where we looked at people's self-reported exercise and activity early on, and then we looked at where they were in the cohort by their formal physical therapy assessments, and we did not find any difference.
Yeah.
So
No,
we did not find
I agree that this is most likely something specific to dysphenodenopathy. So we have a lot of data where we can now look at, we have MRIs from all of these patients as well over several years, so we can now look, are there specific muscles that are more affected in those patients, for example, that have a higher percentage of fat. So these are things that we are currently looking into.
So limb girdle type specific perhaps, and we don't have the final answer.
So next question is, what is the importance of breathing exercises, hydrotherapy, and physical therapy in LGMD? And maybe you could take this.
Maybe I should take that one.
Sounds like you.
So the role of the physical therapist for LGMD is to try and minimize your secondary complications from what you're experiencing with your symptoms. I don't think we have the confidence or the knowledge to say that, and the evidence to say we're going to change your disease course as such. If you do heaps of exercise, that's not necessarily going to change your disease course, but it is if we can use stretching, if we can use splinting, if we use appropriate equipment, that we can maximize your independence in what you're doing in your daily life at home and at work and your social by appropriate physical therapy. I'm a big fan of hydrotherapy because the water allows you buoyancy. It gives you freedom of movement that you may not have otherwise on land. And by eliminating gravity, you have more freedom of movement. You can have more pain-free movement if pain is one of your symptoms. Trying to find hydrotherapy pools that have the appropriate access if you are non-ambulant can be a nightmare. Our Muscular Dystrophy Association in the UK did a survey looking at access to hydrotherapy, and we had more pools available for dogs than we had for people, okay? And I'm sure that in the US we have a similar issue in finding appropriate facilities for doing hydrotherapy. But if you do have access, it is a really nice form of exercise. But again, it comes back to whatever exercise you're going to do, it needs to be enjoyable. It needs to be something that's a lifelong commitment that you actually enjoy doing. And then the second part of the question, Jen?
Breathing exercises?
Okay, so for the majority of the limb-girdle muscular dystrophies, there's not a strong respiratory component. We do see it more in FKRP or R9. Again, our evidence base for breathing exercises is limited. I think what is actually more important is to ensure that your breathing is monitored on a 6-monthly or yearly basis when you attend your clinic. And then that way, by monitoring your respiratory function over time, we then know if it is being affected by the disease and when we should look to introducing something like nocturnal ventilation if required. But breathing exercises in themselves is not something that I utilise as a physical therapist in my treatment.
Cough assist?
Cough assist, yeah. So if your respiratory function becomes impaired and you have difficulty coughing and you become prone to chest infections and you're looking also maybe to use a ventilation, non-invasive ventilation, then a cough assist that Volker's just mentioned, a manual inexaflator is a really useful adjunct, either pre or alongside non-invasive ventilation to support coughing. So some people use that, not so much in our limb-girdle population, but in our other neuromuscular conditions, use cough assist as their physiotherapy for their lungs, because what it does is it helps inflate your lungs and your ribs need to move like a bucket handle. And if you're not able to take your own massive inspiration, then the cough assist helps by giving you a big deep breath in and moving those ribs and keeping that bucket handle movement. But that is more common in some of our other types of limb-girdle muscular dystrophy. But just what's really important is monitoring your lung function on a yearly basis at least.
I'd like to just add too that from my experience, which is limited, But just to say for pulmonary function, if you're not getting it regularly taken and you have an elective procedure, that you should get a full baseline evaluation of your pulmonary before you go in for any kind of elective procedure. So just make sure that you are fully checked out. And if you're not getting those regular baseline, or you're clinically, say, normal and don't really have a problem with that, so you haven't been getting checked out, but you're going for a surgical procedure, that you should be completely evaluated by the appropriate pulmonologist and physical therapist to make sure that you're okay, not only prior to the surgery, but throughout and after.
And is there anything that that's a trigger to make the disease worse? Things that people could avoid doing?
You want to say that?
I think Volker earlier mentioned keeping a healthy weight, because if you're weak and you have more to carry, it's like carrying weights. And so maintaining a healthy weight.
I mean, there are anecdotal reports that a viral infection can all of a sudden trigger a decline fairly rapidly. They have been published in the literature as well. I have seen this as well, but we don't really fully understand what's happening there, whether a virus infects the muscles and causes an inflammation and you rapidly decline. But generally, there is fairly little that we can currently do to really change the cause of the disease. I know that these questions exactly aim at what can we do to change the cause of the disease. I think this is why we need more effective drugs.
So the next question is, this is a person that's newly diagnosed, and they want to know, how do I determine if my cardiologist, neurologist, et cetera, knows what I need?
Dr. Wicklund, do you want to take that one?
So that's a tough one. Fortunately, all the other people aren't in the room that I would offend. So, so I think the easy answer is, if you have access to someone that is involved in a particular type of research, such as GRASP, that's not I think you'll find that the care is good. Theoretically, you should be able to go to an MDA center, and you should be able to find appropriate care at an MDA center. But as I look around, almost all of us would say, well, that's not always the case. So I think what you'll have to do sometimes is be your own advocates and make sure you educate yourselves, and then sometimes educate your physicians. And as I said in the respiratory session, for most of you, if somebody ever says CPAP, before they say another word, you should say BiPAP. And then they're going to say, I said CPAP, and you should just say BiPAP. And about the fifth time, they'll finally ask why you say that, and then they'll read up and they'll understand why you said BiPAP.
But I also think that this question exactly shows and highlights why we, and that's the healthcare professionals, basically together with patient advocacy groups, need to work on care standards, so that there's a document that you can actually print out and you go to your cardiologist or your physician and say, these are internationally agreed care guidelines. This is what it says about cardiac monitoring or cardiac function. So we have already done this for Duchenne muscular dystrophy, for spinal muscular atrophy. Exactly. These are patient-friendly guidelines. They have really empowered patients. And yes, we know that we need to do this for the limb-girdle muscular dystrophies. Ideally, we need to therefore have sufficient data collected in natural history studies as well that provide us with the information that we can then pass on. So important homework for us to do as well.
I think one thing too that we could learn from a sister community is, like with the Parent Project Muscular Dystrophy, I know with some of their centers, they actually make them a certified center. So you could have potentially in the future a limb-girdle muscular dystrophy certified center, and that would help with the care exactly as to you just mentioned.
Great, thank you. We're going to move on to the topic of genetics. So I'll have a question for Dr. Straub. If I have a confirmed genetic diagnosis, is there anything additional that could be learned from genetic testing, the types that were mentioned earlier today?
I'm not sure whether I understand the question fully, sorry.
There were a lot, I think it came from, there were a lot of options for genetic testing that were covered this morning. If you have a confirmed genetic diagnosis, is there anything else to be learned, or are you good to go?
I think if you have a genetic diagnosis that is confirmed, whether it was 10 years ago, then there's no need to apply a new test that we have talked about, exome or genome sequencing. If the genetic diagnosis is confirmed, that is your diagnosis.
Okay. Thanks. And on a related note, if you had a muscle biopsy a long time ago, can that be re-examined if you didn't get a conclusive diagnosis, either because there's new techniques, new genes that have been discovered? Can you go back to that?
So yeah, muscle biopsy is a very valuable resource. If it is kept in the right environment, then you can go back, look at new tests that are developed, and we now even use biopsies not just to look if a certain protein is missing, but also for genetic testing. So there are specific genetic tests that you can do with muscle biomaterial that's very valuable if you don't have a genetic diagnosis yet. I would always expect that, first of all, if you're undiagnosed but you know that there's a biopsy in the freezer, that, you know, first of all, genetic testing from a blood sample should be exploited. If there's no outcome, then the biopsy might be helpful. If you don't want to have another biopsy, I'm a big promoter, and you have heard this, I think, throughout the day, that muscle imaging can be very helpful, especially for the limb-girdle muscular dystrophies as well. You can tell by an MRI whether you have a calpainopathy or dysphalanopathy. It's not necessarily pathognomonic, that means disease-specific, but among the limb-girdle muscular dystrophies, an MRI can be very helpful.
Just to comment on the muscle biopsy, if you don't have a diagnosis and you had a muscle biopsy, now would be a good time to call that hospital and say, do you still have it? Because many hospitals discard samples after like 5 years. So if there's any chance you might want it, call them now. And I would also make a comment, and maybe the others from the U.S. at the table could make a comment. Many places in the U.S. do not have the expertise in muscle imaging and interpretation, diagnostic interpretation of muscle imaging that Volker has, Dr. Straub has. So I think many places in the U.S. the muscle imaging is less useful as a diagnostic test than it is in other places. But I would defer to my colleagues.
No, I agree with Catherine. Dr. Matthews to say that you know, the Europeans have really pioneered the muscle MRI and done a nice job, and different centers in the U.S. there's different capabilities, and so you know, for that I would really, you know, defer to the clinician that you're seeing in the U.S. that would, as to whether or not that center has that specific expertise.
Next question. My spouse has an autosomal recessive LGMD. How can I learn if I am a carrier? I have a daughter and I want to know if she has a chance of having LGMD.
So generally, if, you know, we have learned today that these are rare diseases. And they are rare because there are not many carriers running around, and the likelihood the two carriers meet is small. It has happened in many of you, so that shows it's possible, but generally, because they are so rare, we know that the carrier frequency is not very high. So we have therefore, a few years ago, not recommended to do carrier testing in one of the rare forms of autosomal recessive limb-girdle muscular dystrophy. The likelihood increases if there is a relation, if you're first-degree cousins or second-degree cousins, to be a carrier. Now, if you say the risk is still too high, if I tell you that for LGMD2I, for example, it's the carrier frequency in the UK is 1 in 400, you say, oh, you know, that's too high, if there's a risk of 1 in 400, then of course you need to discuss with your doctor whether they would offer genetic testing and if that's covered through an insurance. In the UK it would be covered, But in the US, I would need to refer to the US colleagues.
May or may not be covered, but depending on the type of limb-girdle muscular dystrophy, there could be a much cheaper approach. So even if it's a type of limb-girdle muscular dystrophy that presents with an elevated creatine kinase or CK, then just testing the daughter's CK would be a lot cheaper than doing carrier testing on the spouse. If it's a type of limb-girdle muscular dystrophy with a normal CK, that is useless information.
And I'll say we've dealt with this, and with genetic testing being much cheaper, you can do an entire panel self-pay in the United States for $250. And so we've had spouses that we've told them about that, and they make that decision as a couple to say, $250 is worth it for my risk. And there's still new mutations that could happen, but it much reduces the risk. And there are still free programs out there, so if the patient's a little bit weak or the patient's spouse is a little weak, we can just test them for free.
Okay, so the last category of questions are a bit of a mishmash. The first person asked, how do muscles grow without the deficient protein early in life? So I think this is getting at how come people are developing normally and then get symptoms later in life.
Yeah, I mean,
I made eye contact with Dr. Johnson, so he can take this.
Dr. Johnson, yeah.
Good question. No, that's a great question. I don't think we have a, maybe Dr. Straub has figured it out, but I think it's hard to know, what causes it to trigger. I don't know. Anybody else has a better answer, but it's a good question.
But I mean, there are many, particularly also neurodegenerative diseases, Alzheimer's disease, you all know, that are late onset. And some of this could be because damage needs to accumulate. And so, we know, for example, even in some of the limb-girdle muscular dystrophies, if you look very early, you can see that, maybe the CK might be slightly elevated. Or if you take a muscle biopsy, that there are already some changes. But you just don't have any symptoms because there needs to be a certain threshold that you need to pass before you become symptomatic. Okay? If someone who's muscle healthy would lose 10% of his muscle strength, you might not even really notice unless it happens from one day to the other. So I think a lot of this might really depend, also looking at MRI studies, that it takes a while before you have a functional impact after muscle damage. But it's for the variety of diseases, it's clearly a lot more complicated. Why specifically dysphalanopathies or anoctamin 5 patients only develop symptoms in the late teens or late 20s? It's something we don't understand.
Okay, so another question is, with the MRI images showing fat replacing muscle tissue, are paleo-keto diets harmful, helpful, or have no impact, based on the hypothesis that keto diets burn fat while the body's in ketosis?
Yeah, again, a really interesting question, I have to say, really interesting. No, I don't think that, this is a mechanism that can be influenced by diet. It comes back to what we have discussed previously. Are there any dietary measures or supplements that can influence the underlying, progression of the disease that is genetically determined? And I don't think that a ketogenic diet could do that either. Not, that I have any evidence that. I don't think that anyone has tested this systematically, but I would be very skeptical that you can therefore, prevent progression of muscle damage and replacement by fat.
Thank you. Our time's about up. We need to vacate the room so they can set up for the reception, which is occurring at 7 p.m. But I just want to thank all the speakers.